एक मिनट 2 मिनट वेट करना जरा।
यस सर, यस सर। निशा थोड़ा पॉज कर देना लाइव थोड़ा। Very good evening, everyone. A very warm welcome to our no thrombosis program. Today with us, Dr. Praveen Chandra sir is with us. Dr. Praveen Chandra sir is well-known, in faculty in India. He has, he is the chairman of Division of Interventional Cardiologists from Medanta, the Medicity Hospital, Gurgaon. He is recognized as one of the leaders in angioplasty in the country and specific in a lot of new devices and technologies. He has been awarded for his contribution and services in the field of coronary angioplasty in India in 1998. Dr. Chandra sir has been a distinguished faculty member in various international meetings and was the organizer and director of the AMI course held in New Delhi for 2005 and 2006. He has published more than 100 articles and reviews and abstracts in various national and international scientific journals. So from behalf of MCure, I welcome to Dr. Praveen Chandra sir. And Dr. Praveen Chandra sir is going to take a session specifically on increasing the, even at the present COVID increasing, very pandemic is increasing. And we can say the COVID associated coagulopathy is a major problem at present in Indian patients. So today, Dr. Praveen sir is going to take a session on COVID-19 coagulopathy. Sir, over to you, sir.
Thank you. Thank you, Ravi. And I'm going to share with you the slides for this presentation today. And as you already mentioned that we are going to discuss about the COVID-related coagulopathies. And I hope you are able to see my slide now. Okay, fine. Yes, so sir. Basically, COVID has created a lot of havoc in the past. In the second wave, it was very bad. Although fortunately, in the third wave, we are not so badly affected in sense of severity of the disease. But of course, we know that it is a very highly infectious disease and it can take a turn anytime. And some patients are having severe disease, but the number is very low. So how do we manage? Because one of the complications of COVID was that it leads to coagulation disorders. And these disorders can be in the form of major thromboembolic complications like disseminated intravascular coagulation, microthrombus formation, venous thromboembolism, DVT, pulmonary embolism, coronary embolism, coronary stroke, acute ischemic stroke, limb ischemia, and whatnot. So you can imagine the whole body goes into a very immunothrombotic state, which explains the micro and macro thrombotic manifestations of COVID-19, which can happen in the arteries, which can happen in the veins. Now, why does it happen? Because they are pro-inflammatory cytokines, which are released very rapidly in the blood and leads to abnormal clot formation and platelet hyperactivation. So Some of this is just releases and plasma thrombotic state, but not all patients will get it. So who are going to get it more? Those patients who are elderly, those patients who are having, who are male, obesity more prone, those patients who had severe pneumonia and increase in state. Now, what are the findings which we get? Number two is mild prolongations when we found the manifestations of the mortality risk in the complete center for the hemostatic abnormality. Then, of course, the problem is not so much, and these patients may require just a very systematic dose of low molecular weight heparin prophylaxis. But in stage 2, when the D-dimer levels goes up very rapidly, then we need systemic, actually, double dose of low molecular weight heparin or full dose of low molecular weight heparin and inhibition of contact system activation. And in stage 3 disease of the lungs, and in these patients where most of the the lung is affected and there is increase in D-dimer levels, in these patients there is hyperinflammation, and in this the problem is too much. And in here we have to give these patients, put in the ICUs and start them on low molecular weight heparin on a full dose basis, and sometimes even thrombolysis is required. So empiric full dose anticoagulation can be given based on the risk of thrombosis and overall low incidence of bleeding, because we have to always balance between the risk of bleeding versus risk of thrombosis. It should always be considered in that perspective, and there are various these scoring systems which are available to know which patient has high chance of venous thromboembolism, and if the score is more than 4, as you can see here in this Padua score, then that means this has a high chance of thrombosis. But at the same time, we have to also assess what is the risk of bleeding in this patient. So if there is a liver disease patient, renal disease patient, patient has history of stroke, there you cannot go full blown giving all the anticoagulation. So which is Has-Blood score. So Has-Blood score tells us whether the risk of bleeding will be high or low if you start giving him anticoagulation. And then there is a risk of assessment for DIC score. And here, if the score is more than 5, then this patient is probably having high chance of DIC. So in these patients, again, we have to consider treatment according to the risk stratification. Now, on the clinical basis, in the hospitalized patients who are above 18 years of age, what is the recommendation? All COVID patients admitted to the hospital should receive anticoagulation therapy prophylaxis unless contraindicated. So in critically ill patients, they need Dvt Prophylaxis. And if there is a high suspicion of risk of thrombosis, where the D-dimer is more than 5,000 or has rapidly increased more than 5 to 7 times, in these patients, we have to give prophylaxis with enoxaparin in the hospital, full dose. And if the kidney functions are less, then we have to reduce the dose of enoxaparin. So this is how we give the antithrombotic therapy. And then indications for therapeutic anticoagulation in those patients who are still at home, they can also be given if the risk is high. And enoxaparin 1 milligram per kg is given to these patients subcutaneously twice a day. And this is the high dose prophylaxis. And DOAC, which means direct oral anticoagulations, and warfarin are not utilized in critically ill patients, only to be given in those patients where we want to give extended thromboprophylaxis, and this can extend up to 45 days post-discharge. So these patients can be given rivaroxaban 10 milligrams orally, and in renal and liver patients, of course, we have to avoid. And in those patients where the creatinine clearance is very, very low, then they can be given enoxaparin 40 milligram once a day. So this is the recommendation for the use of anticoagulation, whether it is enoxaparin, which is subcutaneous, or oral tablets, which is rivaroxaban, to be given in these patients. Now, what is the clear recommendation for NOACs during COVID-19? Because many patients were getting it in the last wave, and many patients actually develop complications also. If you don't select the patients carefully, this can happen. So COVID-19 patients with DIC risk, we can give low molecular weight heparin. And if these patients have heparin-induced thrombocytopenia, then in these patients, NOACs should be switched over to NOACs. NOACs means rivaroxaban, apixaban, or dabigatran. And what are the advantages of NOACs? They are effective inhibition of activated coagulation in DIC. This is an alternative choice in heparin-induced thrombocytopenia. And the only disadvantage is that they are not suitable for mechanical heart valve patients and severe renal or liver dysfunction patients. And also, there is an interaction with antiviral medications to some extent. Now, extended anticoagulation, once the patients are discharged, who are the patients who to be given? So here, if the patient has an improved VT score of more than 4, and those patients who are more than 75 years of age, or who have high D-dimer value of more than 2 times, and age, if the age is 40 to 60, and with a D-dimer of more than 2 times of normal, and a history of venous thromboembolism, these patients must be given extended anticoagulation for 45 days. And those patients, who are up to 14 days of low molecular weight heparin, we can switch them over to rivaroxaban, 10 milligram once a day, up to 45 days of therapy, or apixaban, 2.5 milligram 2 times per day. So all patients cannot be given this because there are some contraindications, and contraindications can be renal insufficiency. In these patients, warfarin is preferred over DOACs with INR monitoring. And in those patients where the GFR is very low, apixaban 2.5 to 2 times per day can be used. And in very, very low, we have to avoid DOACs, which is GFR less than 15, very low renal functions. So basically, this is how we decide. And if the creatinine clearance is less than 30, enoxaparin 30 milligrams subcutaneous once a day or heparin can be given to these patients. So what is the drug interaction of these drugs with the antiviral drugs? And in here you can see that all the 3 NOACs, which is apixaban, dabigatran, and rivaroxaban, have drug interaction with atazanavir and lopinavir. All these agents have interaction. And with remdesivir, there is no interaction. Favipiravir, no interaction. And with Tosli, there is a mild interaction. And with hydroxychloroquine, again, there is a mild interaction. So that is how we have to know when we are prescribing rivaroxaban or apixaban in these patients. Now the question is, what is the clinical evidence? Does it lead to improvement in patients in terms of mortality? So here you can see that the risk of mortality was found to be less by 27% at 30 days, and inpatient mortality by 31% if prophylactic anticoagulation was given to these patients in the very beginning and within 24 hours of hospitalization. So that is why all these patients were given anticoagulation therapy, and this was shown in this study. So, so now you can look at this data from Mexico of oral anticoagulation with rivaroxaban versus thromboprophylaxis in patients recovered from COVID-19 pneumonia. And in here you see that during the first and second month of follow-up, the incidence of thrombotic and hemorrhagic event was low in patients with history of severe and mild pneumonia. So here you can see that these patients, if they are given these therapies, it was studied again in Magellan study and Mariner study about the post-discharge prophylaxis in medically ill patients. And you can see that at 10 days and at 35 days, rivaroxaban was non-inferior to enoxaparin for standard duration prophylaxis. And for extended duration, rivaroxaban reduced the risk of venous thromboembolism. So basically, one can just start as the time of discharge rivaroxaban and continue this as a simple oral medication. And there is no need to even monitor the anticoagulation levels. So this study, the Mariner, demonstrated efficacy of post-hospital rivaroxaban use for prevention of venous thromboembolism, and 28% reduction in fatal and major embolic events without a significant increase in major bleeding. So this is a nice, good, safe dose to be given to post-COVID patients. So rivaroxaban 10 milligram daily was seen to be found to be very effective and did not increase the chance of bleeding. In patients with in those patients who are to receive thrombolysis and thrombectomy, these patients should not be withheld. I mean, they should be sent as soon as possible and should not be, stopped from getting, because this is a very important treatment in these patients in the times of COVID-19 pandemic. So in patients with high risk of embolism, a follow-up and 3 months thromboprophylaxis is recommended, and FDA has approved rivaroxaban at 10 milligrams daily for 31 to 39 days in such patients. So to summarize, the clinical presentation of COVID-19 associated coagulopathy is that of a very highly thrombotic state. And anticoagulation is recommended within 24 hours of hospital admission and has been shown to reduce mortality in severely affected patients. NOACs may be ideal when it is difficult to differentiate between COVID-19 induced and heparin-induced thrombocytopenia, and extended thromboprophylaxis up to 45 days. This is a very good agent to be given to these patients. And clinicians can consider NOACs as the optimal choice when oral anticoagulation therapy is indicated in the outpatient setting during the COVID-19 pandemic, because you don't have to monitor anything. It's a very simple drug to be given. So thank you very much. I think we can have some discussion here. I'll stop sharing.
Thank you, sir, and a very insightful presentation. We can see there are many, chat box is really full, and many questions have been asked by. We can see, sir, at presently around 734 doctors are live and they're watching this session. And the first question, sir, I'm going to take is that Dr. Prabhakar has asked, what will be your treatment plan for patients with COVID-19 who are at high risk of bleeding risk?
I can't hear. Can you repeat again?
The patient who are in a high bleeding risk, in such kind of patients, how we can manage the treatment for COVID-19 coagulopathy?
Okay, so we have to assess what is the risk of bleeding and what is the risk of thrombosis. If the risk of thrombosis is not high, there is no need to give anticoagulation therapy to these patients. Like, for example, these days, with the patients who are coming up now with the Omicron variant, again, the risk of thrombosis is not high because the disease is not severe. The levels of D-dimer are not high, the CRP levels are not so high, and the lung infection is also not so much severe at all. So in these patients, it may not be necessary to give anticoagulation therapy, especially if the risk of bleeding is high, which you can know by the Hasbled score or the previous history of the patient. So that is how we have to balance the risk of thrombosis versus risk of bleeding. That is what we do normally, because we do use a lot of anticoagulation in our patients who are coming with thrombotic events like pulmonary embolism, like venous thrombosis, like arterial thrombosis and valve cases. So we have been using all this. So we have to be very careful to select the right dose for the right patient.
Thank you, sir. Thank you. I think Dr. Prabhakar got your the right answers. And next question is related to what you already answered, but I think I will take other question. What are the cutoff D-dimer or other marker cutoff values to identify coagulopathy? Dr. Charan has asked.
So I think, I couldn't hear very carefully, but clearly, but the thing is, I think the question is, what is the cutoff level for the D-dimer?
Yes.
So let me tell you, D-dimer is a very, very insensitive test. Do not get driven entirely only by D-dimer. D-dimer only helps us in patients. So you have to look at the entire clinical profile of the patient. If the patient does not have severe disease, if the CRP is not elevated, 800, 1000 doesn't matter. D-dimer goes up very, very insensitive. Be driven only
because now the D-dimer is the only marker they're going to take. Is that is this indicative of pulmonary
having same sign or is having, and the patient also is to look out for definitely embolism is significant or not. And if in these, then the test to do is pulmonary CT angio, which is also known as CTPA, CT pulmonary angiography. And this is very simple to be done. And it gives the 100% diagnosis whether the patient has developed pulmonary embolism or not.
Thank you, sir. And one more question is that at present in third wave, most of the patients are in a home isolation because of low level of saturation. So after discharge or after negative report, can we suggest for D-dimer or it is not required?
I, I don't think we should suggest D-dimer on a very frequent basis because it sometimes misdirects the patient's treatment. So as I said already, everything has to be considered in the complete clinical profile. If the patient suffered from a severe disease, definitely then the patient qualifies. And if the risk of thrombosis is high, then this patient qualifies for prophylaxis up to 45 days. But if there was no disease at all, if there was nothing, only isolated increase of D-dimer, I don't think we should give anticoagulation to everybody. Only to those patients who are having high risk of thrombosis and low risk of bleeding, then we should give this drug.
Thank you, sir. I think more or less all the questions are same here. I think you have answered most of the questions, sir. I think, sir, one more is that now in recent trend we can see as the most questions are resembling that only because more and more home isolation patients are increasing. The management of a home isolation patient is very different because as you suggested that the parameters are different, and, for the patient, those who are in home isolation, the patient, those who are hospitalized, the saturation level we need to check, and other parameters also we need to check for all the reasons. But what you really suggest for all the home isolation patients, what kind of treatment protocol they should follow specifically for the home isolation patients?
So is there a question there?
Because the management of our home isolation patients, what the specific here? What is your suggestion, sir?
Yeah, for the home isolation, I think presently in this Omicron wave, for home isolation, any patient who does not have any signs and symptoms of lung involvement, they just should continue only, paracetamol and symptomatic treatment and nothing else. Just monitor saturation levels and watch for symptoms. But in case the saturation is going down or the symptoms are increasing, then only we should start considering, shifting these patients for hospitalization, doing a CT scan, and then making the next decision whether this patient needs to be admitted, whether this patient needs to be given anticoagulation therapy. All these things have to be considered at that time.
Thank you, Praveen sir, and thank you so much. I think we have done it. I think most of the questions we have answered it, and it's really very insightful because we can see we have invited most of the consultant physicians here, those who are involved in this COVID-19 treatment, because I think they got a lot of benefit from this session. And thank you so much, sir, for today's session. From your MQ, again, I want to say thank you so much to Dr. Praveen sir for the wonderful sessions. Thank you, sir.
Thank you very much. Okay.
Thank you, sir. Thank you. Stop कर दो, शेयर लाइव स्ट्रीमिंग स्टॉप।